I would like to say thank you, Dr. Levy, again for joining us for these presentations. Thank you again to the Beals family for being here as well. We really appreciate it. All right, so my talk, the title is Femoral Osteochondral Allograft Transplantation to the Capitellum, Determining the Best Radius of Curvature Fit. So again, I would like to thank all of the people who helped out with this research. We all know research does not happen in a vacuum and usually takes a lot of time and effort, and happens on nights and weekends, as we're all familiar with at this point. So moving on. All right, so I have no relevant disclosures. There were no relevant disclosures to this study on any end. So small amount of background here. Osteochondritis dissecans in general is just a disease resulting from focal subchondral bone necrosis, which leads to sloughing of the chondral surface of the bone. So it is, again, separation of cartilage, which leads to loose body formation, which can be associated with pain and dysfunction, especially in adolescence. So the reasons for this, there are a number of etiologies. What's most commonly thought of is a continuous microtrauma or overloading due to the vascular supply to the distal humerus, specifically to the capitellum, this watershed area, which leads to focal necrosis at that point. It's most commonly, OCD in general, again, is most commonly seen in adolescents in their knees and elbows on the lateral aspect of the medial condyle is the most common location. Ages 12 to 19, 2 to 1 male to female prevalence, and it always varies in severity. Specifically in regards to the elbow, there's only about a 3% prevalence in the pediatric population. Again, mostly repetitive trauma from these overhead athletes, such as pitchers, gymnasts. It's almost always in the dominant arm due to these axial loads or repetitive microtrauma to that lateral compartment. So when we look at OCD lesions in the elbow and how do we treat them, first line is always non-operative. The majority of studies out there show that if there are open physes, a non-operative line of treatment, these mostly will heal. Almost like 80–90% of the time they will heal on their own with no intervention. If they go on and degrade and fragment and they're unable to heal, you can do fragment excision. You can also just debride and do marrowstimulation, fragment fixation, or osteotomies to vary the focal joint mechanics and hope that that can eventually resolve their problems. However, those all have varying degrees of efficacy and are not the focus of this talk. And this talk are the worst ones, the worst of the worst, the osteochondral, the ones that are requiring either autograft or allograft. They've either failed this fixation or need it for other reasons. So again, autograft transplantation is well described in the literature, and it has good outcomes, but it's technically demanding and it has significant donor site morbidity. And there's also a very limited area of donor site available for harvest. And these procedures are done on the pediatric population for this specific etiology. So you have a pediatric athlete and now they are going down, not just one, but now they're down 2 limbs in their recovery. So that can be a problem. So people have looked into the FOCAT, which is femoral osteochondral allograft transplantation, which can be beneficial in this setting as well, and has the majority of the benefits without the negatives of putting out 2 extremities and the additional surgical site morbidity. And there are several clinical trials that have showed positive results in long-term follow-up for these patients as well, both in the pediatric and in the adult population, specifically high-level pitchers. So what are the problems with allograft? The tissue availability is definitely a big problem. There are all of these graft types are described. Again, these are fresh allografts. So these are patients who have recently expired for some traumatic reason or other unknown reason, and these are harvested acutely, so it's and kept alive with different tissue washes and things like that. So These are what are described to be available. However, if you look at what is actually available, so all of these, if you look at the left, these are FDA approved. And as you go through the payers, only a few of these are actually will be paid for by certain commercial organizations, and some of them only one, which is the femoral condyle. So again, processing of these grafts is very expensive and time consuming, and which is why the femoral condyles are the most widely available and most used. So that's what we have, that's what has been described in the literature for use in this specific defect, because it's, again, widely available. However, there is a significant amount of guesswork that goes into choosing a site for the allograft transplantation to pull a plug of this osteochondral segment and from the allograft and placing it into the capitellum. So there are studies that have looked at radius of curvature to try and find what would fit the best. So you're taking a plug from the distal humerus and you're trying to put it into the elbow. And how do we know that you can find something that fits? So these studies have looked into either cadavers or based on CTs for other parts of the body to try to find good fit matches. So that brought us to our research question, which is what graft site from the distal femur will provide the best graft fit for transplantation to the capitellum? And what's the probability of obtaining a random allograft with a similar radius of curvature to the native site at the capitellum? And we wanted to answer this radiographically. So for study design, we went to the IRB and were approved to do a cross-sectional analysis of all OHSU patients with imaging of the elbow of the knee from January 1st, 2014 to December 31st, 2018. We queried the radiology system, which happens to be IMPACS at the time. And so yeah, all of these images were queried. We then wanted to take those images and we wanted to also generate a protocol to measure the radius of curvature, a reproducible protocol from the CT scans, and then compare the radius of curvature of the potential allograft sites to identify the best fit match. So again, our objectives to analyze the native radius of curvature of the adolescent capitellum and compare it to the radius of curvature of the medial lateral femoral condyles as donor sites, and then estimate the probability that we could translate these to each other. So our inclusion criteria, again, were ages 11 to 21 initially. We wanted to scan all elbows and knees, any CTs that were available of the elbows and knees. This was a small population, just by nature of them being pediatric patients. So we were able to find enough elbow scans. However, we needed to expand our inclusion criteria for the knees in order to get enough allograft comparisons, as well as, the allograft population is likely over 21 the majority of the time. So our exclusion criteria, if there was any evidence of an intra-articular fracture or prior surgery or degenerative joint disease, or any anatomic variations that would not be amenable to measurement. So in total, we found 91 upper extremity scans, 130 lower extremity scans, excluded 62 of the uppers and 46 of the lower extremities. We then used a random number generator to select 15 studies for our initial evaluation. So we selected 15 knees and 15 elbows. We then used these CT scans. Again, for this data that was selected, these patients were, the average age was 15, or there were 15 of them ages 11 to 21. And then the knees, the average age again was 56. Our protocol development, so what we did was we used the axial CTs and to measure the radius of curvature. We found the longest axis on the AP and then the corresponding point on the sagittal radiograph, or the sagittal CT, to measure two different points on the posterior femoral condyles, both on the lateral and on the medial. And we measured down from the physeal scar, and then we measured up from the joint line to get some areas that were not overlapping but that gave us a 10 millimeter segment that we could calculate a radius of curvature from. And again, this was published on Protocols.io separately. For the elbow as well, we use the anterior humeral line and the center of the head of the radius to form the center of our circle on the capitellum. And we chose it on the AP, the coronal view, sorry, the elbow, a point that was 4.2 millimeters medial to the cartilage bump, which is a known described anatomic place on a CT. So we had 4 measurements taken from each knee, and then 1 area of measurement from the capitellum, just due to the small size of the capitellum, and then the radius of curvature was calculated off of our 10 millimeter segment. So we had, again, 4 10 millimeter harvest sites on the posterior region of the medial and lateral femoral condyles, and these images kind of show those representative sections and where they appeared on both our CTs, and then a little diagram just kind of showing a pictorial representation of basically where we were looking. Also a representative image of the capitellum. So we then took these numbers that we measured. There were 2 researchers who performed these measurements, as myself and our awesome medical student who helped out with this process. And they were we compared these measurements between ourselves, and then also did our own intra-rater reliability. So we came back and measured them again to look at them. And so what we found was overall, so again, the overall intra-rater reliability was really high for the medial femoral condyles and not so great for the lateral femoral condyles. We also found there was significantly more variability in lateral femoral condyles overall, which kind of harmed our reliability. So radius of curvature in general, what we found is the capitellum tends to be about 10 millimeters squared for the radius of curvature, whereas the medial femoral condyle on location 1, which is lower, happened to be significantly larger, 14 to 22. Location 2 was a little bit closer with 13 to 18. And then the lateral femoral condyles, again, looked a little closer, 14 to 18 or 14 for location 1. However, there was significant variability in this location. So then we also looked at the differences in radius of curvature between the recipient and graft sites. And what we did was did a random pairing of about 15,000 different sites using a computer-generated program, which found a difference of radius of curvature of average about 5.2, with a range, again, from 1 to 10 at the location 2 on lateral femoral condyle. And this was the closest that we could get for a fit match. And so moving on again, this is grafts within 3 millimeters of the donor and recipient site, which were just overwhelmingly closer at location 2 at the lateral femoral condyle, here with a 13% good fit match. Again, this 3 millimeter proportion, this is something that's described in the literature of what would be an acceptable, within the random guidelines that have developed over time. 3 millimeters has been stated as acceptable offset. All right, so our findings overall, the method for, we developed a novel method for measuring the radius of curvature based on the CT scans. There were no actual direct matches between the femoral condyle and the capitellum. So the main thing that came out was there's nothing that directly matches. A random generation overall for these different sites provided about 6% match overall. But that location 1 on the lateral femoral condyle provided a close match or a good fit match about 13% of the time. So this was, in that last line just describes that place. So strengths of this study, we were able to develop a new technique for evaluating radius of curvature for transplant purposes, which is a non-invasive, non-cadaver-based study. We published these protocols online. That's very reproducible for other aspects of the body. And this particular study may aid in graft site selection for surgeons who are moving forward with these type of operations to maybe minimize their potential OR time if they know where they're looking for the graft. Limitations, again, we based these measurements on the subchondral bone on the sagittal views, so that may not accurately mirror the radius curvature of the chondral surface. We also did not measure in the coronal plane, just due to this being a preliminary study. There were no direct fit matches again. And this may not actually be applicable to most community surgeons, just due to access to the allografts. They're, again, very expensive. They're hard to come by. And community surgeons may not have access to them. So those are my references, and I'll open up the floor.
Congrats, Dr. Robbins. That was fantastic. Dr. Levy, what did you think?
Yeah, I mean, listen, this is, this is a unique problem. And even if you take an autograft, you have mismatch all the time. And I remember when I used to do this kind of work, and you could potentially get the bone to sit down, and then you would be like beveling the cartilage around to get the edges flat. I mean, it's really tricky surgery. So anyway, I think that the study is fantastic and really brings to light that we don't have a really good way to match up that area. So let's go through the paper quickly.
Yeah.
So in your abstract, again, there's no defined purpose nor hypothesis.
Yep.
And you have multiple purposes, including, this 15,000 CT generated thing. So you've got a good purpose there, and your hypothesis could be that the radius of curvatures don't match, right? So ample room for that. In the methods, there's no numbers anywhere. So it doesn't say how many CT scans. It doesn't talk about the 15,000 generated things. And then this is all just the abstract, okay? And then in the results section, you've got ROC and XL2, and nobody knows what that is now. So same thing in the background, ROC needs to be spelled out. It's the first time you're seeing that.
Yeah.
So even in the abstract, you have to put, not have abbreviations. And in the results, again, it doesn't say how many. I didn't even know at that point if it was patients or cadavers. So I'm reading through this whole abstract, and I'm trying to figure out what did they measure. So the abstract needs to definitely be clarified on what you did, and your slides were crystal clear, which is a theme of the morning. Okay. And in the results, you don't mention the intra and inter reliability data, but you do in your methods, right? You tested it, but then you don't say what the results were. So anything that you're putting in your methods of things that you're testing, you've got to have a result on, okay? So what's the MCL1? What's the MCL2? And then, yeah, so the where it says discussion, that should be conclusion in your abstract.
Yep.
And then you have the main findings of the study were 1, 2, 3. Well, that's fantastic, but that should be matching your purpose, your methods, and your results. Okay?
Great.
All right. Now, the paper itself, I had a question, why not from cadaver elbows, right? And so you need to put something in there about that cadaver elbows are FDA approved, but currently there are no insurance companies reimbursing for it.
Yeah. Okay.
Okay. Because the whole time I'm thinking, okay, great, you can't find a mismatch with the knee. Why aren't you going to the elbow? You got a cadaver elbow. Why can't you know?
Yeah.
Okay. Otherwise, materials was good. Yeah, and so here, like we observed excellent inter and intra reliability. That is easily to have a sentence in there in the abstract on that.
Okay.
Same thing with the random matching and the 15,000. That should be in your methods. That's a really important thing that you did.
Yeah.
And it's nowhere in the abstract. to me, that was like, wow, that's fantastic. I have a computer generated test and it only matched what 6% of the time gave a fit. That's a huge, huge finding. Okay. Now in your discussion section, this part gets better. So you give a little bit of background, which again, you've already given the background in the introduction. So for me, it should be the key findings of our study are, and again, you have the focus of the study was twofold. Well, there's your purpose that didn't show up anywhere in the paper prior. Okay. And you don't need to repeat the purpose. It's in the abstract. It's in the introduction. And the huge part of your study comes in the discussion section and the paragraph on radius of curvature. So the second paragraph, middle point where it says, after 15,000 simulated matchings using a 3 millimeter cutoff, the MCL2 demonstrated the highest frequency of matching. The clinical implications may suggest a low probability of obtaining a suitable fit. For me, this is the whole paper. So that should be highlighted, in much greater oomph. Okay.
Mm-hmm.
You need a new paragraph when you talk about limitations and strengths.
Okay.
And then in your conclusion, again, we don't need anything about background. So get rid of the entire first sentence and start with this study found.
Yeah.
Okay. Okay. Yeah, your table 2, for me, the table 2 is like the whole key to your paper. And again, it wasn't in the purpose, the methods, or the results. And otherwise is great. I mean, for a unique problem, it was really well done. The way you matched up the radius, obviously, you could do coronals, you can do all that. But I think there also needs to be a whole section on, and a big limit that, and you had it in your slides, that this is bone only, okay? And you may know that if you look at any joint, knee, hip, shoulder, you may see bony abnormalities, and then the cartilage makes up the radius of curvature.
Yeah.
And so maybe an MRI study could be done, which could easily measure the bony anatomy and the cartilage anatomy. And that might show completely different results. I don't do any elbow surgery, and maybe that's been done, but looking at CT and looking at MRI would be another thing. And I think you should definitely mention that in your limitations, and maybe because of that, an MRI study. But it's not feasible. You're not going to be able to do a 15,000 generated thing, but nonetheless, you could do a pilot study and see if the radius of curvature is different from the bones. Great study, great study. I mean, all of these are great. I mean, every single one of these, Ken, has the ability to change clinical practice. And that's why we do research. I mean, it makes no point if you're presenting something that doesn't mean anything.
That's right.
So it's congratulations to all the residents and all the staff and mentors that put these projects together, because anything that can change clinical practice is worthwhile doing.
Absolutely. And thank you so much for all this detailed feedback. Not only very useful for the chiefs and, getting another fresh perspective on their work and wherever it stands, but for the faculty and the residents like listening, kind of a masterclass in, how do you present and produce something, in such a wonderful way. So really, really helpful. And we've all been taking good notes. So thank you so much.